welcome. We're gonna get started with our educational event today.
So welcome, everybody. Thank you for joining us today. We are here to talk about the family clinician partnership that we have started over the years with Mass General and a few parents in the area. And we're going to walk through today. There's a couple of us, two moms presenting, and two clinicians, Dr. Musolino and Dr. Wishart, about the partnership that we've made over the years, and the educational series that you're joining today, but has been in play for a couple of years to bring more education to pediatric stroke and traumatic brain injury survivors, and to help connect parents with other parents. So I'm going to start off, and then I will be turning it over to Dr. Musolino, Dr. Wishart, and Mara. My name is Gretchen Murphy. I'm a mom to an 8-year-old perinatal stroke survivor. His name is Owen. We live in Norfolk, Massachusetts. And how I got involved here is that when I got that diagnosis of pediatric stroke when Owen was born, I didn't know anybody who had that happen to them before. I felt like I was searching in the dark for a light switch to navigate his diagnosis and everything that came with the diagnosis after. So there's a video, Patty, if you want to share. I need to do the disclaimer that this is not for medical advice. We are just sharing our experiences and how we've come together to create this series to help educate others in our community. So it's to educate the community, increase the understanding of unmet needs, and helping others navigate their diagnoses. And I saw, somebody in the chat, I think their son had CP. I'm also trying to navigate CP with a diagnosis of CP for my son myself. So meeting other parents of children with CP has definitely helped me navigate AFOs and what have you. But really, we're here to empower families with data. So in this video that Patty's going to start, you'll see I was out to dinner with friends, and this is my son, and you can see the right foot kind of turned in and dragged, and he had done a couple laps around the table like that. And I took this video and didn't even know where to start, like who to share this video with, what this meant, and what I needed to do to help correct for Owen. So this is around the time that I was going to the pediatric stroke clinic. And I said to Patty, I'm like, I would love to meet other parents that have gone through similar, have similar diagnoses for their children, because I was fumbling around trying to, like, what is CP? What is PT? What is OT? What does my child have? Where do I need to go to get it? What can I expect as my child goes into school? What's an IEP? How do I get on an IEP? So this community that we've created has really helped, at least me as a parent, meet other parents going through the same or similar circumstances, to bond with other parents, and also to learn from other parents in terms of, what is an IEP? How do I navigate that? How do I navigate my child, dragging his foot around? Who do I go to? Do I go to my pediatrician? Do I go to, what is a physiatrist? What is CP? All of this that I learned. And these educational series have been a huge benefit for me as I'm learning not only about the challenges my own son is facing, but challenges of others, and how I can help bridge relationships, set up people to talk to one another, to share like experiences. So that being said, that's my story, and I turn it over to Patty.
And thank you so much, Gretchen. I think if you guys have been following, or this is the first time that you're here, we're very happy that we are connecting. The idea is, as Gretchen was saying, is to connect clinicians, therapists, parents, patients, and learn from each other. And I'll tell you how I came to realize that this was really missing in our clinics and in the care that we provide to the patients and the families. from the hospital perspective and how this has been a catapult of activities and resources now that Mara will elaborate a lot as we continue with this presentation. So I'm a neurologist trained in pediatric and adult medicine, and I do primarily stroke and critical care, and that means when the patients are having acute brain injury. I'm also the co-director with Dr. Grabowski of the Pediatric Stroke and Cerebrovascular program at MGH, and we run this multidisciplinary clinic with Dr. Wishart, our physiatrist, hematologist, rheumatologist, and different therapists that are part of the clinic as well. But we come to it from something that you're probably very familiar with, and I like to start from like the medical side of the journey, and then just very humbly recognize what that is in proportion to the life of a child that has suffered brain injury. And the journey usually starts with symptoms. No, something was off. So you saw the video on Owen's, that foot that was limping. Owen had a very early diagnosis because he also presented with seizures at that time, and we were able to diagnose him at birth, almost a few days after birth. But a lot of patients, and very commonly, start having difficulties with either movement or speech or behavior, or a headache or a seizure, which are not the most common presentations of a stroke in pediatrics, in adults, but they are in children. A much larger proportion of children have behavioral changes, headaches, and seizures, which are not the classic arm weakness, loss of sensation, loss of vision, speech difficulties, and you call 911. So most of the time, pediatric patients with a stroke that are not in the perinatal, right around the time of birth, presenting with a stroke, will present to their primary care doctors, will present to an emergency room, and might be a pediatric or might be a general. And we're all familiar with the very stressful times that we put families through when we're trying to diagnose pediatric stroke or the brain injury, and the reasons are several. The most important one, the earlier we act, the most likely we are to make a difference on what we can preserve of the function of the brain. So there is a lot of effort, research, clinical trials, and a lot of teams working in trying to provide acute care. What I think is less of the kind of training and awareness that we have, but not for Dr. Wishart, that is a physiatrist and a rehabilitation doctor, but for the doctors that are the neurologists and the developmental doctors, is what comes after the kid is being discharged and we send the family home. And that is not a minor transition. Sometimes there is a rehab hospital in between, but many there is not. And they go home. And there is a list of to-dos that you almost have not ever encountered before. Very few families have experience with this prior to the time when their kid has brain injury. You need to adapt your home. There is a list of doctors and appointments that are going to be basically filling the weeks ahead and the month after the discharge. There is a lot of follow-up of test results. There is appointments that also need to be arranged that were left on the parents to arrange, and these are not easy healthcare systems to navigate nowhere in the country. And then going back home and to work and recovery and being functional and happy and thriving in your society. So there is a long time of developing and life with brain injury that comes after a pediatric or perinatal stroke. And there is, in our experience, that's why we call them thrivers. Like children do a lot after brain injury that adults cannot do. And that's why we really have to keep in mind that this is not a journey of the first 6 months, of the first year. This in reality is the journey of their lives. And we need to be there to diagnose, monitor, and support them with the things that are useful. And I'll tell you where I go with this useful. And these unique developmental challenges will make them very special, very empowered. These are kids that are very resilient, have a lot of resources, but will make the life of a family and the child a lot more complex. And they go on, and this is the other one that is a big one. When they transition to adult life and they start their own independent living or work or studies or whatever it is that they want to be doing, there are a transition also in the healthcare system that is not as smooth at all. And in general, it's pretty painful to see how difficult it is for young adults that have survived brain injury as a kid to find the specialists that will continue addressing their needs, which are also changing. So 18 years of training between medical school and residency and stroke and critical care fellowship. And I only had 1 week of rehabilitation training, 1 week and a half of training in Spalding in rehabilitation. And finished my training. And 2013 comes to the clinic. One of my first clinics, the mom of one of my patients says, why do I come here every year, every 2 years? Everything I found for my son, who was at the time around 10 years of age, I have to find it by myself. And I was pretty much getting fired, like first clinic and coming out of the acute setting into the clinic that follows the patients long-term. And it was very clear to me that the reality was I did not know what she was talking about. So I called her outside the room while the team was still working with the kid. And I said, I'm going to ask you a favor. Could you send me an email specifically with what you are talking about? Thereafter, there was a very clear confrontation, which I really don't know any of the resources that these families are having to tap on for recovery, rehabilitation, and accessing of the school system and their daily living. And yes, we have a lot of challenges to diagnose a stroke, and we have all this critical care in the neonatal, the pediatric ICU, the clinics. And then early interventions is a program that works reasonably well across the different states, at least in the US. But rehabilitation services are very different to access for everybody. And then you can put guidelines outside, like in publications, and say, this is how a kid with a stroke should be followed, monitor at what age, what happens. But in reality, what we are really in the very, very native stages of development is how do we really empower, educate, and train the interventions that happen in the family and the community? And how do we intertwine them? And this is how I conceptualize this problem. So I made myself this question is, what is the time that a kid, until it reaches adulthood based on 18 years of age, of awake time will spend in the hospital if they have had a stroke? And this is a super overestimate. It's in reality less than 0.01% of their time awake. So there's usually a couple of weeks. Very few kids have spent a couple of months in the hospital. Then it comes all these early interventions and a lot of the more intense rehabilitations, physical therapy, occupational therapy, speech therapy, depending on the needs. And these things disrupt a lot the life of a child because they need to be taken to these clinics. And that's why I gave it a quite significant amount of weight, not because of the time in therapies necessarily, but the time that it takes the kid from whatever they're doing to get to those services. And according to Google and a lot of papers out there, this is the real time that we spend in formal education. And this is taking from kindergarten all the way to the last year of high school. And this is the amount of time that in the life of a kid, 15% of time. So where is the rest of that time, of that life, of that development happening and the recovery? In the community, at home. And I put early interventions again here because early interventions most of the time happens at home. And the things that an early intervention therapist can teach the parents will go on to be extended into this fragment of their life. So I find it pretty unacceptable that we have so much resources invested on trying to make better and do better here. And believe me, I believe on protecting the brain and making every recovery possible in the acute so we don't have to deal with brain injury. But at the same time, I think we should never ignore the powerful impact of an empowered parent that knows how to look at their kid and what to see. So a medical student took the lead on the first summer, and I basically have the medical student that wanted to do an advocacy project, reached out to all the families that we could contact in our clinic and find what the resources were helpful to them. And in that interactions, we started connecting with parents. Mara was one of the first ones. Gretchen was also among the first ones. And we clearly realized we needed their advice. So we made an advisory council for the clinic in pediatric stroke. And this brings in not only parents, there are also like Bonnie Thompson, advocates that are parents and also part of advocacy groups that are very active in the pediatric stroke or brain injury communities. And we brought also some patients themselves and therapists to help us navigate this. And we opened the advisory to a larger community. It was clear that we couldn't post the resources that we were finding, the families found helpful in our region, in our website in the hospital, because of conflict of interest. Many of them are private practices. So a nonprofit organization was created. And because I carry another hat of a scientist that studies the genetics of a stroke and how genetic disorders can cause a stroke in children, I had to do both in one. So this and the Young Genetic Stroke Alliance basically has the genetic side and the research, and also has the rehabilitation and the educational series on it. And the idea was that we get all the stakeholders together and we put the resources in a place where people can really vet them and not have conflict of interest, because this is a nonprofit and is what people find helpful when we're posting in there. So very quick, brief review of what kinds of strokes are there. And then I'm gonna focus specifically on the most common type. And I think even if it's not the type of stroke that your child or yourself have suffered, I think it's important to know there are different kinds. And it's important to know that once there is brain injury, the challenges can be conceptualized the same way. And I will use an example of one particular domain, and then Dr. Wishart will walk us through the other domains as well, just to exemplify how understanding some of the neurological underpinning as a parent or as a patient can change a lot of the things that you're doing and can enhance the recovery. So the type of strokes that you can have are arterial ischemic, the blood flow stops. You can have a clot that basically occludes the drainage of the brain, the venous system, or you can have a vessel that ruptures and blood goes into the brain. And I'm gonna focus on the arterial ischemic, which is a vessel occlusion, stops the blood flow to an area of the brain. Usually, even if you get really quickly to reopen these vessels, which is our goal in the acute care, there is an area of the brain that will suffer in minutes, and it will have an injury and a scar. There is a lot more brain at risk. This is where I was saying all the efforts are in the acute care, in the stroke care, and in critical care, to try to preserve this area of the brain at risk. And children do a pretty good job themselves on keeping this area preserved. And as you know, we use medications after a stroke to impair the platelets from getting sticky to the vessels, and we hope that that way we can prevent a secondary stroke. But the risk for a secondary stroke are very complex in children, and they need to be elaborated one by one. We should do a seminar on that alone. So it's very important to know what vessel got affected during your stroke. And this is important for, I think, not only the clinicians, but for the rehab doctors, for the therapists working with the kid, and for the parents themselves. So interrogating where was the injury. And usually because the brain has territories where one vessel, for example, here in blue and red, is all provided blood flow by this middle cerebral artery, MCA, is important, because if you have a stroke that affected that area, then you know what areas of the brain function map to that area. In this case, the receptive language and expressive language. And you can start predicting, because maybe this is a baby that is not speaking, what areas could be at risk and need to be monitored and intervene early on to maximize their development. And when you take the brain and you put it down and you do MRIs, and I can here put a schematic of an axial section. So it's a slab of the brain in the MRI, and this is an affected brain and how it should look like. And in this particular sequence, the brightness is the ischemia, the suffering of the tissue underneath that is sensing lack of oxygen. And that's where the territory has been affected. This is a territory of an MCA. And you can see here the scar of this particular patient a year and a half after that injury. And I don't know if you guys noticed that the scar is only this area here. It's not matching the acute injury. And this is one of the areas that we really need a lot more research. There are patients that will end up with a small scar, and there are other patients with the exact same acute injury to the brain will end up with a much larger scar or loss of tissue. The factors involved in this definitely include the interventions that these brains in development are getting exposed to, but there are also many other factors that are genetic and predispositions from their own brain and inflammatory systems, et cetera, et cetera. So it's not simple. And what I want to leave everybody with the message, if you are one of the newly diagnosed, is do not let anybody tell you what is your child going to look like, because we do not know. And you can talk a third and a third and a third. That's a classic explanation when you really know what is happening specifically to the patient. So we do know that if you have certain areas affected, there may be challenges in the functions that need to be learned in that area. So the brain has a map for everything. And that's how we also look at this. No? So if there was a scar or an area that is affected in the acute setting and includes the motor areas, we are going to be looking for motor disability, weakness, spasticity. For visual areas, we need to track that the development of the vision is happening. We cannot wait until they are 2-3 years of age and then ponder, because we might have impaired their ability to develop the visual acuity. So there is a place for everything in the brain, and knowing what area was affected, it helps the therapist, the neuropsychologist, even the teachers to understand some of the challenges. And the brain has such an exquisite map that every part of the body gets mapped to a particular type of the part of the brain with the neurons that project in the case of the motor, or that receive information in the case of the sensory, for example. And here you see what this will look like if we make it a 3D map of the number of neurons that represent the movement of the hand. And you can see you have a lot more hand movement than thigh movement, or it's not less movement, it's less neurons to move the thigh than the amount of neurons that you engage to do fine motor functions. And you can see here, and I want to put this in the pictures specifically, the mouth and the hand are mapped very close to each other in the brain. And if you notice any baby, and I'll show you now an example, this is something that is part of how we learn to map our functions and our sensory and our world. And it's that integration between the hand and the mouth in the early development. So I'm going to walk you through the motor system. And we're going to go through videos specifically just to see how understanding what is happening can help you change the way that you treat the kid and enhance the ability to learn and to recover. So for the motor system is one of the ones that we have the most understanding. There is a neuron, and this is what this purple thing is, a motor neuron up in the cortex, where I was showing you if this is in that place, it will be mapping to the hand. And it's coming down through the brain, it crosses, and it ends up all on the other side of the body. It connects with the green motor neuron, which is in the spinal cord, and that one will go and find its muscle. So here is the other part of the schematic where you come out of the spinal cord into the muscle. And there is a sensory neuron that is constantly sensing how this muscle is being stretched. So gravity, which keeps us attached to the earth, is constantly pulling our muscles down and stretching them. And that is being sensed. And this motor neuron in a reflex called myotatic reflex is active and is being used to contract the muscle a little bit so we are not falling to the ground. So we have an anti-gravitatory posture. That's the same thing we do with the hammer. By the way, in the clinic, we stretch the tendon, stretch the muscle that is sensed acutely and is triggering an over-exaggerated contraction because we did it very roughly. So that's the reflex and how we tend to test it. And you can hear the neurologist saying that reflexes are increased when there is upper motor neuron injury. If there was a stroke, this neuron may not be connecting as much as it used to with the lower motor neuron, and this reflex gets released. And the release of that reflex makes the muscles stiff. And that's what we call spasticity. It's the release of a lower reflex that keeps that neuron that should be used for movement occupied with keeping extra tone. The extra tone is the spasticity itself. So how do I use this concept of how the motor system works, what happened with the injury and stroke? And here you have a baby that is 7 weeks of age and is sitting in the car seat, is supported. And you can see the right hand and going towards the mouth and how the fingers are being moved. And you can see the left hand on the other side that is lifted. The head is to the right. There is a reflex there. It's called fencing reflex. And if I ask neurologists, residents, or anyone, what hand is affected here, if there was a brain injury in this child, and the answer is usually, I don't know, or I most of the time get the left one, not the right one. Let me show you a picture of the baby 4 months later. And the truth is, very early on, it's very difficult to see asymmetries on a baby because a lot of the reflexes are lower down and they don't require the upper motor neuron. But as they've developed around 4 months, and you can see this baby now lifting the head, that's pushing a lot of strength, anti-gravity, and is activating the motor system. And now you can see the right hand is fisted while the left hand is open. And this is where you start seeing the asymmetry and the hemiparesis. And for those that have a diagnosis of cerebral palsy hemiparetic, this is what it looks like. And that's how some kids get to diagnosis. And if you consider what we just said, that gravity is really acting on the body all the time. If we put the baby at the same age on their belly, and that's a very common recommendation, belly time, belly time, belly time. You can see what the hand on the right can do. It's very close, it's almost a claw, and it's not able to open, it's trying to reach the toy, and it loses the ability to experience the toy and grab it or play with it, because as it keeps the body up, there is activation of that spasticity, and it cannot really use the full repertoire of those fingers. Let me show you what happens when we make gravity a little bit more in our favor. And here the baby is lying on the left. Their right hand is going towards gravity, towards the tip of that pillow. And you can see how this hand, the right hand now, is able to open up fully, how it's able to grab the tip of the pillow. The kid is also moving, if you guys notice, the feet at the same time, and is babbling. So there is a lot of activity that is happening. It's all movement, and it's multisensory. It's looking at the pillow, and it's on the side. So you can see how being on the belly has very much impaired the ability to experience the world with the right hand versus being on the side. And let me finish with this video, which I think captures the message here, which is take something out of the challenge. In this case, the baby's lying on their back. There is no gravity applied to the body and the head, so they don't have to be concerned about activating their whole motor system to not suffocate. And not only that, the baby catches the mirror of that hand by the shadow. And there are specific neurons in the brain, in the frontal area. They're called mirror neurons. The first ones we have activating to smile, which is one of the first motor voluntary things the baby does. And is now using not only the sight and those mirroring neurons, but also brought in the other hand, which has more sensation than the affected hand, that also has impaired sensation, to map it with the motors, with the sensory system, the tactile sensory system. So now it's mapping with the visual system, with the motor, the motor system itself, the proprioception, how the arm is moving, and also with the contralateral, like tactile system. So to that brain that is trying to relearn a function, this baby is providing a multi-sensory vision, proprioception, and tactile experience of that hand. And you can see now the fingers are moving one by one. It almost, you can never tell this hand is affected by a perinatal stroke, which is what this baby had. And it's the baby on the MRIs that I was showing you. The injury was 2/3 of the dominant hemisphere. And why is this important? And this is where I'm gonna getting close to my part and pass it on to Dr. Wishart. Because a parent that is understanding of this function of gravity and sensory can develop a lot of things that can impact the day-to-day activities, changing, feeding of that baby. And I just put in here one of the monthly sheets that this mother prepared in consultation with the things that she was learning from therapists and from doctors and her own knowledge to daycare. And this is how she was empowering the daycare people that want to do the best with the kid to do things that could be helpful to this child that is not neurotypical, that has a brain injury, where a few modifications can really make a huge difference. And now we are impacting that 75% of the time, or that 15% of the time, if you want to put daycare into the school side. So if we really want to maximize brain development and learning, which is the way that I think about after a brain injury, I don't think about rehab and recovery. I think about development, because that's what's happening in pediatrics. We really need multimodal integrative experiences. That's because that's the way the brain learns. If we go on repetition of a single task, I don't think we are providing the right substrate for the brain to learn. And therefore, it's limited what you can accomplish with doing one thing over and over and over. Once you have the skill, you can perfectionate it by repetition. And kids do this all the time. And then variation is the next thing that I will leave everybody with, is if there is something that we need to do, is not be super safe about the baby being in the same 2 feet square place, but varying the environment. So they have things to explore. They have experiences that are different. And that could include taking them to the grass or taking them outside or putting them in a chair and then in the bed. And you saw the baby on different environments just by the nature of the videos. And then there is a developmental sequence. We do not start doing fine motor activities as a baby until we are able to support our trunk and sit independently. You don't do a pincer grasp, that's around 9 months of age, until you're able to sit, which is around 7 months of age. And that it has a reason. And one of the reasons is what I was just showing you. If I have to support my head and my trunk, I am activating the motor system in a way that my fingers will not get to experience a lot. And then healing from brain injury is recreating these sequences, but recreating them with consideration of what area of the brain was affected. And that's what I usually try to pass on to the families I interact and meet in clinic and in the acute setting, is that we really have to follow their own developmental sequence. And it's not so hard once we start looking at them and what they're really working on. And I will pass this on now to Dr. Wishart, which is going to elaborate a lot more on this trajectory and journey of the developmental sequence and how that changes in kids that have had brain injury.
Wonderful. So I'm Brian Wishart. I'm a pediatric physiatrist or physical medicine and rehabilitation, PM&R, all different terms. Just to give a quick overview, we focus on function as sort of the definition of what we do. Our goal here is to think about quality of life, activities, not necessarily each individual, this is what we're not good at, this is what our brain injury was, but overall, what is this leading to and how are we interacting with our environment, interacting with our life and participating, and how can we enhance that and improve that? So I want to talk a little bit and just expand, as Dr. Musolino said, on sort of the development and developmental sequence. We all think about, and when we go to the doctor, and honestly, when we learn about this in medical school, we learn about development in multiple different domains. So we think about our gross motor. We learn to roll, we learn to sit up, we pull to stand, we start to take steps, so on and so forth. And then we think about our speech with a couple words at age 1, and then we increase, and then we start putting words together as we get older. And same thing with the fine motor. We think about our pincer grasp, or grasping, or raking grasp, and then our pincer grasp, and going on with that. And often it's thought of in these distinct sequences. We're going to do this, this, and this from a gross motor standpoint. And then separately, we're going to do this, this, and this from a fine motor standpoint. And, we know well our growth curves. We often talk about how is our child growing when they're young? Are they meeting their goals? Are they moving along their growth curve? But there's definitely a curve that is associated with our development. I think what's really important here, and we see this sometimes when we talk about our growth curves, when we think about like our BMI and that sort, is that there's a relationship between these, and they're not just within a vacuum. We're not thinking about just our gross motor. We're not thinking about just our fine motor or just our speech. And the reality is that each one of them interacts with the other one. As Dr. Musolino was saying, you're not reaching out and really utilizing those fine motor skills until you have that good base for you to work out of. You can't reach out far if you don't have good truncal control. And you're not going to have good truncal control until you're comfortably sitting up. And so typically when we start sitting up at 6 months, and then by the time we get that under control and are able to do it without putting a ton of energy into it, we're at about 9 months when we start to think about that pincer grasp, and we're reaching out and we're doing much more from a fine motor standpoint. We see this on the speech with gross motor. Kids are putting a lot of effort into their gross motor development when they're early on in those early stages. And it's not until they get really comfortable with that. Typically, we see kids becoming much more stable with their walking, where they get a longer stride length, they get that heel strike, which just indicates they're really comfortable on their stance leg, standing on one leg, around 18 months. And after that is when they start to really put a lot of that energy, or developmental energy, if you will, into their speech and their communication and their cognitive stuff. And we see that language blossom around age 2 typically. And so all of these things are important when it comes to each other. When we're thinking about children that have had a stroke or some sort of brain injury early on, often we're not seeing that typical development. And it may be in one domain, it may be in multiple domains, it may be in all of them. But it does change how we think about those interactions. It changes how we think about that developmental sequence. And I think when we're going through this, we need to really think about what our goals at that age are. What are we really working on? You know, absolutely, we want to follow their developmental sequence, but if they're cognitively intact and they're cognitively have not been affected and they have a small stroke within the motor strip, there may be a lot more energy that's getting put into that gross motor development, that gross motor sequence that might be limiting their speech development. And maybe we can help them and we can be focusing a little bit on one or the other, depending on where they are and what's important and what's holding them back. Are they seeming frustrated because they can't communicate as well? Are there things that we need to work on and that we need to focus on? And that's the conversation we should be having at each visit. What are our goals at this time? What are they doing? Where are they struggling? And how can we help them to move along in all domains? And I have speech, fine motor, gross motor up here, but there are other domains. Our social domain is so important. And one of the things that we often see can get neglected when we're so focused on these motor milestones as we're going through. And they're so focused on therapy and that sort. So we really want to focus on developing that whole child and getting them back up and getting their skills back up to where they were. You know, we talk about rehabilitation quite a bit, but the reality is a lot of these children that have had strokes early on, we're rehabilitating them for the first time. They've never done this skill. This is a new skill that's just coming later than the typical sequence. And so we have to take into account all of that development and assist them in achieving these developmental skills for the first time and not missing those windows for these to initially acquire these skills. The other aspect that we sometimes see, and we have children that have had strokes later on in life. They've been developing, they've been meeting their milestones, they've been making these gains, and then there's a sudden loss of some nature of skill. And I think the important part here is to recognize that our rehabilitation in these children, these younger children, is superimposed upon that typical development, that typical growth. There's other aspects from learning their independence and trying to figure out their identity and who they are that is ingrained within their development as they're going through, and making sure we're thinking about that stuff and thinking about what's important to them. We talk about this often with athletics. Children that have had some sort of injury or something like that, they may have been quite involved in athletics, or maybe they enjoy it quite a bit and they identify as an athlete, and now they're having a difficulty keeping up. And how do we maintain that identity and maintain that physical activity as they're going through this and moving forward? And it comes back to what we talked about in the last one. You know, at the end of the day, we want to make sure we're thinking about our goals and thinking about what's important as we're going through this. And I often have to keep stepping back when we go through this. You know, we want children to walk. We want them to move forward, and we want them to learn how to take those steps independently. But why? So they can participate, right? They can keep continuing with their friends. They can make those relationships. Why? So they can have an enjoyable life and they can move forward and they can learn to interact. And so I think if you're able to continue to step back as to the whys of doing these things, we'll recognize what the value is. Sometimes that's hard to think about. You know, we really want our children to learn these new skills. We want them to be able to take those steps. But there are times when we're just going to struggle. We're not going to be making those gains as we typically want to. And that's when we want to start thinking about, okay, we were really focused on recovery or that habilitation and learning those new skills, but it's holding us back in those other domains. Maybe our gross motor, our truncal control isn't quite what it is, but our children are ready to start feeding independently, reaching out and using their fine motor skills. And maybe we need to use something like we have up in the top right that helps them with that truncal stability and gets them up into a stable position so they can start reaching out. Maybe they're inquisitive and they're ready to start exploring and learning about their environment, but they're walking and their gross motor skills there are not quite up to where they are cognitively. And we can use something like this standard that gives them the freedom to move around independently. And these are the times when we really want to be thinking about our goals and our focus of therapy, our focus of what we're trying to accomplish at that time point for that child, to think about, do we want to continue to just focus solely on that recovery, or maybe we need to think about some accommodation for them so they can focus on those other domains and that whole child picture. And, you know, when we go through all this, again, why? At the end of the day, it's so we can have those relationships, we can have that enjoyment, we can have that quality of life, and we can get out. And this is Owen from that first video with a brace on that leg, out playing golf with his dad and enjoying, you know, typical life and getting out and being able to do the things that we really want to do. I think this is what's important. And this should be the goal that we're really thinking about at the end of all of this stuff as we're going through these therapy plans, accommodations, bracing, equipment, and all of that. So I'm going to leave it there and pass this on to Mara to talk a little bit more about the whole thing that we're doing here. Thank you.
Thanks, Brian. So I'm Mara, and the baby that Patty was sharing about is my child Echo, and I'm going to share a little bit more about our story. Before that, I'll introduce myself. Beyond being a parent to Echo and Echo's older sister, Zoe, I now lead this education and outreach program. I co-chair the advisory council that Patty mentioned with Gretchen, and really to build and bring resources to more families like yours. So a big part of what my section is celebrating what we've done in the last 5 years, and also inviting all of you to partner with us so that we can continue to bring more of what you want to you and make a difference in your life and your family's lives. Oh, it looks like I can advance, or did you advance?
I just did that.
Okay.
Sorry.
So this was probably at 1 day old for Echo, my younger child, and you can see sort of on this theme of all the videos that Patty was showing that my two children are each involved with their hands, and the hands are so important in the brain. So Zoe at 2.5 years old is looking at her thumb, trying to understand how her baby sibling is sucking their thumb. And next. Unfortunately, shortly after that first picture, I had sent Echo to the special care nursery so I could get some sleep. I was a cesarean mom, cesarean birth, and the hospital pediatrician came in and told me your baby's having seizures. Oops, back up. And said your baby's having seizures and needs to transfer to a larger hospital. So Echo was transferred alone to a larger hospital, to Mass General. And this was when I first saw them in the NICU at probably 3 days old, because we were separated for 30 hours. Okay, I think I can advance. No, next. So my kids now are 16.5 and 14. Echo is the tall one on the right. Most of the time you can't really see obvious evidence of their stroke. They're in high school this year and playing soccer and ice hockey. Next. And of all the moments, of course, you saw some moments as an infant for Echo, but I like to share this pair of videos of Echo learning to do something. So here's Echo a couple months before turning 4, doing the monkey bars. And you see Echo's right hand is affected, and Echo gets to that 3rd rung and is struggling, but doesn't panic, knows how to fall, and wasn't wrapped in bubble wrap, had all kinds of varied, rich childhood experiences. So in the next video, this is the same t-shirt, but 4 months later. So now Echo told me, Mom, let me do those monkey bars again for you. Same exact playground. And you can see they're faster, more confident, swinging those legs. Tongue is still involved. That's a little bit of extra, not needed movement, but very proud, right? Proud, but really not looking to me for validation, just doing it because it's joyful. Next.
All right, I'm just going to pass the slides off to Patty because I have a sick little one here that
Okay.
attention. So I'm just going to stop sharing real quick. Sorry.
Do you see the slides, Mara?
I see them, but you gotta go back. Okay, next. Great. Okay, so the celebration is we've been doing this 4.5 years. In April of 2019, we held our first workshop, and it was in person at Mass General Hospital, in conference rooms and with families, with clowns, really getting to know everything there could be about pediatric stroke. And at first, we didn't really know how to focus, or we wanted to include the whole team. So the first one was kind of long and a little overwhelming. That was some of the feedback we got. And the second one, we narrowed the focus to neuropsychological and educational aspects of rehabilitation. And we, again, had probably 20 families participating, and kids could come in and out, and there were small group discussions with parents of different ages. So we started in person, and we were on track to continue that in the spring of 2020, but COVID disrupted that, as many other things. And so we pivoted to go virtual. And in hindsight, I'm very glad that, not for COVID, of course, but that we had the opportunity to go virtual, because we're reaching now many more families. So we're like almost 4.5 years since that first event. We've delivered more than 40 sessions. As today we have 22 here. Typically we get somewhere between 20 and 80 attending live. Many of our videos have been viewed hundreds of times, some 1,000+ times. And we reach people who live in big cities like Boston or Boston metro area or New York, but we also reach many families who are more remote in the United States, Canada, and around the world, who don't have the same providers and access to care and resources. And we're super proud of all of our network that we've built, and I'll be going into that more as we go into the next slides. So as you know, because you're all here, we reach families directly through the pediatric stroke clinic that Patty and Brian and I work in. And we also reach families through social media, partnering with the IAPS, the International Alliance for Pediatric Stroke, and their network of families, and then sharing into Facebook groups like CHASA and KISS. And we also have our own mailing list that continues to grow. Next. So this is just an example on our website that Patty mentioned. It's called YGSA, Young Genetic Stroke Alliance, but we sometimes think of the G as Global Stroke Alliance. So we have links to each of our sessions, and this is just showing last year, but these all go out to YouTube. And on YouTube, you can change the language of the captioning and access it regardless of the language that's most comfortable for you. Next. So following Brian's section about development, I think of our educational series as something that's been under development really since 2018, because we had to prepare for our first event. And as Patty clicks through the years, you can just see that each year we're gaining more and more partners to join us in running these sessions. And these are a mix. They're a mix of educational entities, healthcare entities, and community partners, small businesses. Next. I said I now work in the stroke clinic too, and it's not just behind the scenes. Since March, Patty invited me to come into the clinic sessions, and I get to listen to most sessions. And it's pretty common that there's one theme. So a family might at that moment be mostly struggling with something about school, or mostly struggling with something about behavior. And with this library that we've built over the last 4 years of these videos, we can then direct them to the most relevant educational information through these QR codes, and we're working to find better ways to do that. And part of the network is also connecting families, clinicians, and researchers. So I'm also co-chair of the Parent Council for iAcquire, which is the first phase 3 clinical trial for pediatric rehabilitation. It's a constraint-induced movement therapy research trial for 8 to 36-month-old infants and toddlers. And so we've done sessions on constraint-induced movement therapy and partnered with those researchers on iAcquire. Next. We also, especially in the face of coming out of the COVID isolation, really wanted to come back together in person for those close enough to join us in the Boston area. And we've now had 2 annual events outside Spalding Rehab Hospital that were like a festival or fair, really focused on fun activities for kids that also allow the parents and caregivers to connect with each other and with their providers. And we're planning our 3rd one of those in May 11th, so save the date for that. We include a passport for social emotional development so that the kids are interacting with each other and with each of the stations. Next. And they're just some more pictures of some of the stations. Perkins School for the Blind is one of the stations. And in this video of find the blue car, you can see how much longer it takes the child with cortical visual impairment to find the blue car in an increasingly noisier scene. So this is another research study that's integrated with the Pediatric Stroke Clinic and another partnership that continues. So these relationships that we build through the educational series then lead to long-term partnerships like this. We started to have our partners our prospective partners reach out to us. So somebody had met me through iAcquire and asked to join us. And this is Sudha Srinivasan from the University of Connecticut. And she asked if she could bring her cars to our Play to Thrive event in May. And it was not long before May. I think this was in April, maybe 2 or 3 weeks beforehand, but we said yes. She came, and it was one of the most popular things. You can imagine kids age 3 to 8 would be delighted to ride in these cars. And even more impactful, since that, she's been able to enroll several kids in the research trial that she was really struggling as a researcher to recruit enough families to participate. And now she's close to meeting her goals with recruitment. Next. And we also involve students so that we're educating the next generation of providers. So this is Jen Packard, who's an occupational therapist at Spalding in Salem, and she was leading our adaptive bike section, but here she's orienting the student volunteers who came from the MGH Institute of Health Professions, and she's orienting them to this population, how to help them adapt the adaptive bikes for each child. And it's really exciting and engaging for them. Next. So you see, we always get so many volunteers. And one thing we learned this last time is we invited mostly PTs. So now Jen was teaching them, and she's like, we should invite more OTs and more SLPs. So we get all those domains that Brian was talking about, speech and fine motor and gross motor, and resources for families in all those domains. Next. This is just, you can see the individualized attention that each of our kids gets. Why it's not too many to have, 15 volunteers. Go ahead. Team Impact is another nonprofit we've partnered with. They match college sports teams to kids who might not feel part of a team. And CP Soccer is a program. I also lead the New England team. You can play the video clip. Oh, the sound might not be on, but basically we got heroes of the match for our CP Soccer New England team. And through Spalding, Brian and our team were able to secure a grant to bring several kids from the New England region to New York City for a day camp this past summer to join 10 kids from New York City. So we're looking to expand on that kind of programming as well. And that's what I just spoke about. We're partnering with a professor from Columbia University, Catherine Dimitropoulou, for that research. Next. And Cerebral is a company that ran the indoor stations, and they had both tactile, hands-on things to play with, as well as adaptive things to play with. The boy on the left is tilting his head to drive the Mario Kart. And the girl on the right is learning the voice commands that she can use to make, I'm not sure which game she was playing, but to make things jump or go left or right. Joe Walsh is a longtime partner from Adaptive Sports New England, here showing bocce. Next. And then it's just part of childhood, sort of augmenting the fun of being outside with other families on a beautiful day. Next. And again, our volunteers built a tunnel and let the kids come through, and there were bubbles. So we're really celebrating what we've done in the last 4.5, 5 years, and also looking to all of you to help us move forward with what's most pressing, what's most useful to you. So I'm going to shift the view to gallery and invite questions. I see Jordan's putting some, if anyone wants to come on camera, so we have more of a community feel. And I'd love to, Jordan, if you're able to ask your questions.
Hey guys, thanks again. Sorry you have a sick child at home. Yeah, I have a more general question around like when to intervene, therapeutically, and when to accommodate. And what prompted this particular one in our case is that in 3rd grade, our district starts Chromebooks and typing, which my 3rd grader can do with such effort, like having had so much OT. And I wonder, like part of me is like, okay, yeah, keep on encouraging that, because any use is great use for his affected fingers and hands. But on the other hand, when I think about what Dr. Wishart said about why, really the why is we want him to be able to communicate and not be trapped by his body, which is what the goal of school and in general for him. So that's a particular example, but I think it applies through so many things, 0 to 8 that we've encountered.
So I'll answer the typing question specifically, because you also had reached out to me about that one. I think that in the context of accessing the curriculum in 3rd grade, things start to go quite a bit faster. And so I think that anything that slows you down with respect to that is going to be an impediment. So if an accommodation needs to be dictation, it's so much easier now to dictate and have the software have the text there that then the child can edit. And then you're also then avoiding the frustration of the thing that the child can't do. So my child, I can't even tell you exactly how they type, but it's almost entirely with their left hand, and they use their right thumb and maybe the right index finger to hold the shift key, and maybe occasionally some number keys. The last 3 fingers of the right hand, if they try to use them, they are not accurate enough to do it successfully, and they get really frustrated, and I like backed off entirely and let them figure out how to find their way to type one-handed, mostly. So that's my 2 cents. I see Patty and Brian nodding.
Yeah, I mean, I think it's about, what are the goal? We want him to be able to utilize that device and that technology. And if he's able to get through it in a different way, I mean, I use Dragon. I can type quite well and pretty fast, but not as fast as I can text to talk, talk to text. And so when I've got a million notes, I pull up Dragon and go through it. And so I think it's a technology that has changed quite a bit. And Enable Play that we had put, Cephaly now that we had put up has some new technology that's even faster in terms of how quickly it takes your talk and puts it into the text and isn't having to run through everything. So I think sometimes it's both, right? You do want to be working on it and trying to improve that function, but at the other side, he wants to keep up, right? He needs to do that reading. He needs to learn those other skills. And if it's being held back so much by his ability to type, then we need to use those other accommodations and those other technologies to make sure he can learn the curriculum and keep up with his skills. That doesn't really relate to his fine motor control of that one hand.
I echo both in the approach, and also like the not cutting it also forever. Like these are transitions sometimes that they might end up deciding that they prefer to type, and they prefer to type with one hand or one hand and 2 fingers. And it might be a back and forth and a swing. I think the really difficult challenge is to get both allowed, and just also because it's a kid and the teachers don't know sometimes if their kid is not cooperating from a kind of a behavioral standpoint, or if it does it because it's getting. I think it will be great for anyone that has to keep up, and mostly this particular 3rd grade transition. And Brian, you taught me this in a very simple way. You learn to read from like kindergarten to 3rd grade. In 3rd grade, you read to learn. So that is happening at all levels. So the speed and the volume is really exponentially increased in 3rd grade. So that will be a time where I will very much advocate for having all the accommodations possible put in place on a 504 and the IEP, and really having honest conversations with the IEP group or the special eds person, say he may or may not use them. So he's not only giving one option. Then there are other things that I think there maybe Dr. Wishart can point to who has this kind of adaptations, but the keyboards are very non-ergonomic for anyone, guys. So, and if you have to bring your hands into like this position of pronation, there are other keyboards that can be experimented with. And we can ask to a certain extent things to be tried at school, but the truth is the teachers have many other students most of the time. So you may want to try a couple of these things at home, like trying different keyboard that is splitted, keyboard that has elevation, keyboard that is nothing but just a little shoulder where the wrist rely for one hand, for both hands, for the contralateral hand. It's really a matter of giving the possibility for him to explore and see what is working and not working. And there will be fatigue. And I think that's something that we all have to be prepared for. And the fatigue is real and is more in kids that have brain injury. And I do want to say that because sometimes what is the deal breaker is the breaks that you allow a kid to have. And those accommodations need to be part of the IEP too. That if they're working on a task, that they are allowed extra time or they're allowed to take a break from the task. And the teachers are usually pretty good at giving you something else to do in the meantime, if it's not that task specifically, or letting you go out and take some time. So I think the fatigue will be there, the exploration is necessary, and there is extent that can be asked from school, and the other things that your parents are gonna have to deal and trying to trial at home. And always asking the OTs also, if there is an occupational therapist working with him, they also much more familiar with the adapted devices that may be there. And I do want to put a call out to these voice recognitions is a world difference in the last 5 years. So Ryan was talking about Dragon. Cerebral, I was in Play to Thrive and I tried my own and I was like, oh, this is faster than my Dragon. Like, so I just want to say they're working with the community, they're engaged, they want to help, reaching out to them and saying, hey, could you give us a sense of what devices or what software or what applications you would recommend? That's why we are building the community too. So you guys can tap independently of anything that we do in these conferences.
Yeah, I don't want to derail the conversation to another rabbit hole, but the voice to text, we have some concerns too, because for the last couple of years, especially the curriculum he was in, that was a balanced literacy, not a structured, it's had reading challenge, which has now been helped with structured reading outside tutor, and then spelling. So we wouldn't want the voice to text to obfuscate the reading and writing and spelling challenges too early. But anyway, just sharing that in case other kids had those compounding challenges.
Melanie, you had your hand raised. Are you still able and interested in asking your question?
Yeah, I'm sorry. I just have so many questions that I thought I'd better just not. Yeah, I mean, I have, yeah, so many questions. I don't even really know where to start. So I'll just listen. Sorry.
Well, maybe one question. What's the age of your child? What's your top concern right now?
Well, I talked to you in the past. My daughter's 16, and you know, one of the things that I've been dying for her is finding resources of other kids that she could reach out to and talk to. She feels so alone and so isolated, and she hates being called special needs because she doesn't feel like she is, you know, and she knows many special needs children, and you know, she's definitely not in that category. And so to be able to talk to somebody and be able to relate to them, I think would be so helpful to her. So that was one of the things is, you know, I think I've reached out to you, Mara, before and just said, is there any resources or anything that kind of groups the kids together? And then another aspect of what I struggle with is her IEP. The school has really fought us hard on, you know, they're like, there's no other child in here with this many accommodations. And I'm like, well, you also don't know anybody else in this school that's ever had a stroke. So you can't say that and you can't compare them. And she sits in a class with kids with, you know, she's in the high school now, so they wean out all the kids with ADHD and those kind of disabilities. And, you know, she's only in there with kids with dyslexia now. And that kind of help is not the help that she needs, you know? So just things like that, resources, just, I feel like I've been in this 16 years and I'm still trying to find answers to a lot of questions that I have.
I hear you, Melanie, and I think the challenges are dynamic. That's the nature of the kid also growing, and maybe you got something to work at some point, and now it's a very different need. With respect of the other kids, several of our teenagers, by the way, are very outgoing, outspoken, and very happy to connect. So I think Mara, you and others in the call, it's not so difficult to reach out. One thing that I will also recommend, if she hasn't tried this, is if she wants to watch the adult panel that we did, the YouTube.
Jordan
And
just
some of
shared
those
the
guys,
link.
yeah, some of those guys are very happy to connect. And I have seen in the Play to Thrive and the CP Soccer how the older children are now teenagers are really mentoring the younger ones. And that sometimes is what it takes to really start feeling that you have a place. It's like, not only you're different, but there are other people like you, but you're very much needed. Okay. And that changes the role of having to learn to thrive, to teach to thrive, or to help someone to thrive. So that can empower her very much. with the school, it's a tough one. One thing I do, and Dr. Wishart and many people in our system do, and you could resource this to your neurologist and neuropsychologist, is to really have them in the IEP meetings. I know this sounds crazy, but it works. Takes a little bit of coordination. The schools are usually open to have someone that knows about the brain disorder, the injury, or the evaluation participate in these meetings. And that usually goes a long way because it gives them information they don't have also. So regardless of what you bring them to the school, there is a dialogue that can be conveyed. And there's also advocates for parents when you're feeling that the school doesn't really understand or gets what you're trying to ask for. There's more in the room that I will pass on to.
Yeah, we've had some things with, involving attorneys and everything. Our neuropsych person that did the evaluation, he wrote a very long report that was very helpful, but he definitely doesn't have the time to come to our meetings. And with all the coordination of who has to be involved, they give you that 30-minute slot that you just have to take. And so getting everyone there is near impossible. But yeah, thank you for all that information.
And I just want to chime in. This isn't, I think it was our second in person. The social component was really brought out on the forefront, and that, so many of our older kids are finding that, so much time was spent in therapy, so much time was spent in special ed classes and pulled out of their general aspects, that social development really was something that was lacking. And I think that's been one of the parts of us trying to figure out how to incorporate more community activities for our younger kids. So it's not something that, we're getting to the age of 20 or older and we're now saying, oh my goodness, how do we develop this social aspect, but something that's built in from the beginning. And some of, I know we've had a number of kids that have really met quite well through adaptive swimming and other activities. And it doesn't have to be sports, but trying to find something that allows for a little bit of an organic connection to be made can be really helpful. Some of the dance, some of those types of things. I think there's some adaptive art programs and that sort of thing, but it's a real challenge and something that has been brought up.
And for my daughter specifically, like, she's been kind of dismissed from all therapies, and she presents herself pretty normally. Like, she was supposed to have maybe fine motor issues. She actually has a lot of cognitive things, but she presents herself very normally. She's on the JV volleyball team, and what's really frustrating is that she looks normal. And so kids just don't have patience, and she doesn't want to, and she also feels like she doesn't need to, or the people aren't deserving of hearing what her story is, and so she shouldn't have to walk around with it advertised kind of thing. And so that's always been the challenge, is how do you fit into the norm mainstream, and also how do you get that connection like you're speaking of? And it's a huge challenge.
Yeah, so I can speak to that also for my child who is playing JV soccer. And we had to have a discussion before registration, what and how much to disclose, right, on the health form for registering for the high school sport. And I talked frankly with my child, like, you're going to be in the gym doing potentially strength training with this team, and you might need to explain why some things you have to adapt for yourself. And so they wanted the backup of that. But I think it's a real issue, because they too can, like, pass as able-bodied, but CP soccer has actually been super helpful with that, because they've gone to sleepaway camp for CP soccer and met college age Paralympians who inspire them and are open and celebrate their own disabilities. So I know, because my child follows some of them on Instagram, and I can see who is actually really, like, inspiring and motivating them and is open. And I think through that, they start to find their own voice. So, and you're also making me think that we could do more potentially to offer some place for our young adults to connect. So we'll think more about how to do that.
And I'm open to being more involved in that as well. I'm just kind of stumbling on this group recently, and I don't even know all of what it has to offer, but I'm very passionate about this. And if there's anything I can do, I would love to help out as well.
Where are you located?
I'm in like the Cleveland, Ohio area.
Great.
Fantastic.
Patty, there was a technical question about dominant hemisphere from
Yeah, can you re-ask it? I don't have the chat and that question.
Lauren Lineback asked,
I think it's supposed to.
the MRI showed 2/3 of the dominant hemisphere. How do you know it was the dominant hemisphere?
Is left-sided. So, and the way that our brains are mapped for 99.8% of people, the left side of the brain is the dominant hemisphere. And that's set very early in development, even in utero, before 18 weeks of gestation, just to give you a sense how hierarchical that thing is. And what dominant means, the dominant term came from the handiness that a person develops. So if you have right-handedness, you have left dominance. But in reality, the dominant hemisphere encompasses a lot of the primary, executive, communication, motor functions. So language is primarily mapped to the left hemisphere. What we are seeing on kids that have strokes very early on is that they can relocate that map to the non-affected side. So they can play with the non-dominant hemisphere. And that's why most of the kids relearn the way to talk, and they have deficits and difficulties that are much more subtle to see. Sometimes it's the speed on what that they find the words that they want to say that is different, but they can sound completely like normal, but there might be still some challenges there. So dominant refers to the left-sided part of the brain, which is by default in most people the dominant hemisphere. And even for those people that are left-handed at birth, like, or just when they develop, still the dominant hemisphere is usually the left side, although the right side has privilege on managing this hand with more dexterity. But language usually still maps to the left side of the hemisphere. That's why I use that term.
So I'm going to talk about our some of our upcoming sessions. We have, and feel free to add more questions. And next month we have a really important session about returning to school or navigating the return to school after childhood stroke. So we're trying to reach populations that have their brain injury at different ages and stages. And so what is it to be 10 years old and have a major loss of function and then try to return to school? And how do you navigate that? And the child, the mom, and 2 of their private therapists are all going to participate in that discussion. So I think that's going to be really rich and may get at some of the issues about IEPs. The following month is about epilepsy. And then we have a whole bunch in the queue. January about summer camps. We're working on executive functioning. We're working on possibly a session about driving. And there's more that I'm not remembering off the top of my head. Jordan, it looked like you had another question.
Oh yeah, actually, it was a comment about like the getting other kids together or connected. I thought some of the interactions I've seen have been like the wide age range helps because like with my child, when we were at a local CP soccer event, I was like surprised that was in 2nd grade last year. He connected more with a 7th grader. And so to your point, Dr. Musolino, Dr. Wishart, how a lot of times there are delays or they're on their own trajectory, having that wide age range helps. And I was just talking to, I had been texting somebody from the summer CP soccer camp student about something else, and the student shared, junior fall is really tough. It's not going that great, but I think I'll get through it. And I showed it to my third grader who's really dreading school, and he was like, can I please text him back? And he said, you'll do great, like, like, I'm having a hard time in school too. And then that junior texted him back, it's like, we're all in this together. So but like that was just really funny. There's like a high school junior with CP and this third grader who they're bonded with.
Yeah, so in CP soccer, especially the day camp we ran in New York City, we set it up so there were some older kids who were my kid, 14, 16-year-olds, who were really mentoring the 8-year-olds and 9-year-olds and 10-year-olds. And these relationships are very strong, even with 4 or 5 year age gap. They look up to, because they identify there's a connection of lived experience. So I'll send a survey out this afternoon, and I just invite you to let us know your thoughts on the whole program and what you'd like to see going forward. And thanks for your time and attention, and have a great weekend. Patty, you want to say something else?
Yeah, I just cannot escape saying, if you guys know of someone that has the ability to communicate very effectively, that can teach that something they have done with the people that experience, please also point us to those experts. And I'm talking about not just therapists and researchers. We are trying to really address the needs of a kid developing, and that will have all the things that we are discussing right now. So if you know of anyone that you think will be a great resource for the community to have them speak and interact with the community, please also in that survey, we ask you, just put the names. And if you want to be the contact person for that person, or if you want to put their contact numbers, we will reach out to them. And thank you so much for being here.
The topics can be very specific. So I had a mom reach out last week and said that her 15-year-old is on the cusp of the process of learning to drive. And could that be a topic? And we already have lots of ideas about that, and are very excited. So it can be very specific to a function at a specific age, because not every topic has to appeal to everyone. Thanks, everybody.
Thank you.
Bye.